Burns are some of the most complex and devastating injuries we treat. They are painful, costly, and can cause permanent disfigurement. Beyond the immediate damage, they often lead to long-term disability and require months or even years of rehabilitation. But despite how severe they can be, burns are also an area where nurses have an incredible impact. From prevention to acute care to long-term recovery, nursing care is at the center of better outcomes. Let's begin with the big picture. Burn injuries don't just affect the skin. With large or severe burns, the damage touches nearly every body system. Advances in resuscitation, nutrition, wound care, and critical care have improved survival dramatically. But even with these advances, burn injuries remain a major challenge worldwide. As nurses, we don't just treat the wounds. We provide holistic care that helps patients recover physically, emotionally, and socially. Almost all burns are preventable, which makes prevention such an important part of nursing practice. Our role in health promotion and education can't be overstated. Families need to know the basics. Keeping matches and lighters away from children, never leaving kids alone near fire or water, installing smoke and carbon monoxide detectors, and checking their batteries every year, and practicing fire drills at home. We also need to remind people that water heaters should be set no higher than 120 degrees Fahrenheit, that smoking in bed or while using home oxygen is incredibly dangerous, and that loose clothing can catch fire while cooking. Teaching patients and families how to store flammable liquids safely, how to avoid electrical hazards, and how to use a fire extinguisher may seem like simple things, but these steps save lives. Now let's talk about survival and recovery. Worldwide, burns claim over 250,000 lives each year, mostly in low and middle-income countries. In the United States, the mortality rate for reported burns is around 3%. The main predictors of survival are the size of the burn, whether the patient has an inhalation injury, and the age of the patient. With modern burn care, more patients are surviving even very large burns, but survival is only the beginning. Recovery is long and complex, often involving rehabilitation, scar management, and psychosocial support. When we assess the severity of a burn, we look at several factors: age, depth, total body surface area involved, the location of the burn, and any comorbidities all matter. Children and older adults are at higher risk of complications because their skin is thinner and their bodies are less resilient. Burns of the face, or over major joints carry additional risks for function and mobility. Burn depth is another important factor. A first-degree burn, like a sunburn, affects only the epidermis. It's painful and red, but heals quickly. A second-degree or partial thickness burn involves the epidermis and part of the dermis. These burns are very painful, often blistered and wet in appearance. Healing usually takes 2 to 3 weeks, and scarring is possible. Third-degree or full-thickness burns destroy both the epidermis and dermis, sometimes extending into underlying tissue. These burns are leathery and dry, often pale, red, brown, or charred. Because the nerve endings are destroyed, the patient may feel no pain in the burn itself, even though the injury is severe. These burns require grafting and always leave scars. Fourth-degree burns are the most extreme, extending into muscle and bone. These injuries are often life-threatening and may require amputation. Once we know the depth, we need to estimate how much of the body surface has been burned. This helps guide fluid resuscitation and decisions about transfer to a burn center. The most common method in adults is the rule of nines, which divides the body into regions that represent about 9% each. A more precise tool is the Lund and Browder chart, which adjusts for age and is especially important for children. For scattered or irregular burns, we can use the Palmer method, where the patient's palm, including fingers, is considered about 1% of their body surface area. Patients who meet the American Burn Association's referral criteria should go directly to a burn center. That includes anyone with burns over 10% of total body surface area, burns of the face, hands, feet, perineum, or major joints, third-degree burns, electrical or chemical injuries, inhalation injuries, or burns in patients with serious comorbid conditions. Children and patients with complex social or rehabilitation needs also benefit from transfer to a specialized center. Now let's look at the pathophysiology of a burn. A burn wound is not uniform. At the center is the zone of coagulation, where the cells are dead and necrotic. Surrounding that is the zone of stasis, an area where cells are injured but may survive if perfusion is maintained. On the outside is the zone of hyperemia, where injury is minimal and healing is likely. What happens in the first 24 to 48 hours can determine whether cells in the stasis zone survive or die. Burns also cause systemic effects, especially when more than 20% of body surface area is involved. Severe burns trigger a massive inflammatory response, releasing cytokines that lead to capillary leak, hypermetabolism, organ dysfunction, and in some cases, death. Electrical burns deserve special attention. Unlike thermal burns, what you see on the surface doesn't reflect the damage underneath. Current travels along nerves, blood vessels, and bone, generating heat and destroying tissue deep inside. Patients may arrive with small contact wounds at the entrance and exit sites, but internally they may have massive muscle damage, compartment syndrome, and kidney failure from myoglobin in the urine. Flash burns are caused by ignition of clothing, while conductive injuries occur when current passes through the body. Lightning strikes are another form of high-voltage injury. They can cause cardiac arrest, respiratory arrest, and lifelong neurologic problems. Radiation burns are less common, but can cause both thermal skin injury and cellular DNA damage. Let's move through the systemic complications. Cardiovascularly, patients experience decreased cardiac output almost immediately. Plasma leaks into the interstitium, causing hypovolemia, edema, and burn shock. Without aggressive fluid resuscitation, organs and tissues don't get perfused. Even with resuscitation, the early hours are precarious. Fluid and electrolyte shifts are another hallmark of burn injury. Edema can begin within 4 hours and peak around 6 to 8 hours after injury. Potassium levels are high early on due to cell destruction, but later patients can become hypokalemic. Sodium levels also fluctuate and hyponatremia is common. In severe cases, tissue pressure from edema is so great that an escharotomy or fasciotomy is needed to restore blood flow. Hematologic changes include hemoconcentration from plasma loss, low platelets, and prolonged clotting times. Pulmonary complications are some of the most dangerous. Inhalation injuries can occur above or below the glottis. Upper airway injuries are caused by thermal or chemical exposure and often require early intubation to secure the airway. Lower airway injuries result from inhaling smoke or toxic gases, leading to mucosal edema, loss of ciliary function, bronchospasm, and atelectasis. The presence of black soot in the sputum is a key diagnostic clue. Carbon monoxide poisoning is common and deadly. Because hemoglobin binds carbon monoxide 200 times more strongly than oxygen, tissue hypoxia occurs quickly. The treatment is immediate administration of 100% oxygen. Hydrogen cyanide poisoning is another risk in house fires and should be suspected if lactic acidosis persists after resuscitation. Circumferential chest burns can also prevent chest expansion, requiring escharotomy to allow adequate ventilation. The kidneys are vulnerable due to low blood flow, hemoglobin, and myoglobin from injured tissue. Without careful fluid management, acute tubular necrosis and acute kidney injury can develop. The immune system is also profoundly affected because the skin barrier is gone. Cytokine release and immune dysfunction increase the risk of overwhelming infection. Burn centers use strict infection control practices to reduce this risk. Other complications include loss of temperature regulation and gastrointestinal changes. Without intact skin, patients lose heat rapidly and may become hypothermic. In the GI tract, patients are prone to paralytic ileus, Curling's ulcers, and bacterial translocation. Stress ulcers may present as occult blood in the stool, coffee ground emesis, or frank bleeding. The liver and pancreas are also affected, sometimes leading to fatty liver or acute pancreatitis. In patients with very large burns, abdominal compartment syndrome can develop from massive fluid resuscitation and edema, requiring surgical intervention. So when we step back, what do we see? Burn injuries are among the most devastating conditions in medicine. They require not only knowledge of the complex pathophysiology, but also quick recognition of complications and precise, evidence-based interventions. As nurses, we are the constant presence at the bedside. We assess, we anticipate, we educate, and we advocate. Our job doesn't end when the wound closes. It extends to helping patients reintegrate into their lives, their families, and their communities. Survival is just the first step. Our real goal is to restore function, dignity, and quality of life.